the goal of this is to figure out what everybody else does. And that may make you feel better about what you're doing, or hopefully there's something that we're going to discuss in the next 30 minutes. And if we could put the 30-minute ticker up so I don't lose track of time, that'd be great. But the idea is to give you something to take back to your practice Monday morning. Maybe not your neurosurgical practice or your veterinary medicine practice, but you never know. So with that, a couple disclosures. So logistics, this is something that I didn't quite appreciate in the first 2 years of practice, but now doing this for 10 years, the longer you're in it, the more patients you acquire, and the more situations like this. 4 p.m. on a Thursday afternoon, your nurse calls you and says, there's one of your patients who has chronic sinus disease and a history of chronic sinus disease without polyps. You did surgery on them a while ago. And they're calling with 10 days of the sinus. It's always the sinus. It's never chronic sinusitis or pus coming out of their nose or facial pain. It's, I got the sinus. So it's Thursday afternoon, and your Friday is busy. You're either in the OR or clinic, or you're going hiking or golfing or something like that. You can maybe make time. But I'm curious, what do you do? Because this happens, and the longer you do this, the more patients you acquire to your practice, the more often this is going to happen. So I'm going to start on the far side with Dr. Picorni. Al, what do you do in a busy private practice in Spokane, Washington, when a patient calls in and says, I have the sinus?
I think it depends on how well I know the patient. I'll yell, so if you can hear me, it won't be recorded, but I think it depends on how well I know the patient and how recently I've operated on them. A lot of people kind of know their own bodies. A lot of people kind of know their own bodies and know what works on them. We're reasonably disciplined about not just giving out antibiotics anytime. If I've had a recent culture on them, I'll frequently use that culture to guide an antibiotic that I would give them. And I also have the advantage of I have a nurse practitioner that works with me, and we're pretty easy on getting people in on short notice to obtain a culture. So most of my true chronic sinus patients, as opposed to recurrent acute, we will try to use culture-directed antibiotics. And I think 10 days of the sinus is a reasonable time to start an antibiotic if you have that kind of information.
All right. Sarah, Ray, Brent, what do you think? I mean, can't you just treat these patients over the phone, not have to worry about it, just give them some drugs and send them on their way?
Yes. No. No, I'm not done.
So let's
No, I think the reality is that yes, I do that sometimes. I mean, if I have cultures available from previous visits or from operating room, I will look at those. I'll also, usually my staff knows to ask them if they have a specific antibiotic which has been effective for them in the past. So I may go on guesswork and I may give them Augmentin, something like that, if I don't have culture data. But I'm not afraid to treat them without necessarily having a current culture, because my practice is way too busy to just like add every single patient who does this. Not that I have many of these. Well, no, the truth is I have a lot of them. But I mean, we get 6 of these every day, right? I mean, after you've been doing it for 15, 20 years, you just get huge numbers of patients, and so we get lots of these. And so I do look to my cultures. I do try to find out if there's something there, but if not, I'll try to go with a general purpose thing.
All right. Sarah, what about down in Georgia? Those people are a little, they're pretty hardy down there. So do you just tell them to suck it up, or what do you do?
We have a hardy crowd down there, but we also get these very frequently. And I think one of the main things is really knowing your patients. And when they call in with an exacerbation, is this someone who truly gets infectious exacerbations, or is it someone in my area of the country who happens to be really bothered by their spring allergies, which are crazy. So is it more of an inflammatory exacerbation? What have they had in the past? Are they going to need, is it someone who's really going to need antibiotics, or do they maybe need a few days of oral steroids, or do they need to, bump up their steroid rinses for a little while, those sorts of things. We also I have a nurse practitioner and a PA in our practice, and so we do have capacity to get people in rather quickly. I don't necessarily require that people come in before we treat them. Sometimes we see them, in short order, but what I do try to do is either see them before we treat them, or if we're going to treat them over the phone, I ask them, please come and see us in a couple of weeks so that we can make sure that you're back to your baseline.
So Ray, what do you think? I mean, this is just
Yeah,
crazy.
well, I mean,
right? We're just treating headache right here, aren't we?
Well, it depends what they... Firstly, I agree with what Elle said. I think you've got to know your patient. There's some patients that if they phone, you say, just come in and let's see you right now. And the others that you know that this is pathetic. Okay. The other thing is, I don't believe that infection is the cause of all these problems. I think just putting them on a course of antibiotics and saying, call me in a week's time is going to cut it either. I think what you want to know is what they've actually done for it in the last 10 days. How bad is it? And what they've done. And I think that Sarah makes the point. Maybe they need a little short course of oral steroids. Maybe they actually just need to go into topical steroids. Maybe they just need topical saline. Maybe they just need reassurance. I don't think everyone needs to be seen. I think what Elle said right in the beginning is the most important thing. You've got to know your patient. But one thing that is important on that slide is that you've operated on them. And I think once you've operated on them, you take ownership of them. And I think once you've operated on somebody, you've got to actually listen to them and you've got to treat them appropriately. I don't think you can just fob them off. And so I think there's no real answer to that question. The answer is it depends.
All right. Well, I think you're all right. And there's no consensus. But the take home that I'm hearing is it's okay if you don't see them every time. If you have the facilities, the ability to see it, that's probably ideal. I don't think any of us would argue against that. But just logistically, it's a challenge to do, and it's something that some practices are better set up than others. I was going to, well, this is a dark screen. This next slide says medications, ? Which is, we've talked about that pretty well, but I do just want to get an idea. Steroids, yes or no, for this patient, 10 days of sinus symptoms, no history of polyps at the time of your surgery. Sarah.
Usually I would not do oral steroids for this patient if they're not more like allergic or polypoid or inflammatory sort of sinusitis. I try to do a little bit more topical, especially if it's more of an infectious process.
Okay. Right.
So I would probably not use steroids here. I would use just an antibiotic, most likely. And just a caveat, and I'm sure you all are doing the same thing, but man alive, be sure that you record in your note when you tell them, to go on Augmentin. Make sure you record, that you've talked about the risks of Augmentin, you've discussed all of that, and it's all labeled right there and everything. Because, there's some crazy stuff going on out there with regard to the medical legal environment with these antibiotics and stuff, so be careful about that.
Ray, you would give steroids.
Yeah, absolutely. Not oral steroids. I'd do exactly what Sarah said. I'd put them on topical steroids if they weren't on already, and if they were on already, I'd increase the duration, and I'd make them from a daily to a twice daily dosing, and give them a few days and tell them to get back to me on Monday morning when it's going to be more convenient for me to actually see them. But I do think that I would use topical steroids in this situation. They're post-operative. They've 10 days, worsening symptoms. I think you've got to do something. And I'm not convinced that just empirical antibiotics is the way to go. And Brent's allowed to be wrong. That was a joke. Australian humour.
All right. Well, it's interesting that we're talking a lot about antibiotics. And one of the nice things about having Brent and Ray and Sarah, you all were part of this international consensus statement, these international guidelines that came out last year. And when we look at antibiotics, you guys are all recommending antibiotics, but wait a second. In the guidelines that you wrote, insufficient evidence for
Wait a minute. Wait a
recommendation.
Wait a minute.
Whoa.
This is
What are you
acute. This is
talking about here,
acute
Dr. Senior?
Exactly.
This is
Yes.
acute exacerbation of chronic sinusitis, isn't
This
it?
one is a summary for CRS without nasal polyposis, my friend.
But that's as
I'm confused, as is part of the world after these guidelines came out. I thought antibiotics were good.
Well, I think that is the difference, right? I think that, well, first of all, there's so many things, so many people that we're trying to answer to with this treatment. We're not just treating the patient; we're treating the insurance company. So the insurance company is going to have something to say about, how we treat these patients, and they're going to demand that the patient be on antibiotics, right? Especially if you're thinking about doing surgery or something, which we're not in this situation. There's a post-op patient, but again, I treat this as an acute exacerbation of chronic sinusitis, so I think that antibiotics are indeed appropriate for this. Truthfully, I feel antibiotics are appropriate for chronic sinusitis as well. That says that the evidence is insufficient to be able to make a call, but I believe that the evidence, that it's still, in my personal practice, is still effective.
Right. So that chart is actually referring to kind of the management of chronic sinusitis without nasal polyps, not in an acute exacerbation state, right?
Right.
And the acute exacerbation is more likely to be an infectious process.
All right. So there's confusion amongst many people who read these consensus statements. And even though they are guidelines, it's not exactly treatment recommendations on the individual level. So there's still work to be done. This was an absolute fantastic effort by all parties involved. Thank you, the three of you, for spending so much volunteer time on that. All right. I have an idea because you've all mentioned already, but would anybody not take a culture of this when they looked in the nose? Is it worth doing a culture? Al?
Yes, it is worth doing a culture.
Sarah?
So I do culture.
Okay.
I know there are plenty of people out there that don't. I do culture, and I think it helps. I actually had very recently, I had a lady who we've been seeing for 2.5 years who every time we cultured her, it was the same thing. She came in to see my nurse practitioner, and I said, let's get a culture. And she said, my nurse practitioner said, why? Why? It's always the same. We don't need a culture. We cultured it was completely different. So I do.
All right. Ray, what's your
Yeah,
thought?
I culture.
Yeah.
I think that it's worthwhile culturing. I think that it certainly guides you, and I've never ever regretted taking a culture, but I certainly have regretted not taking culture.
Good. All right. So here's our good friend Pete Batra reported on a retrospective review, 105 patients. They changed antibiotics 77% of the time. So that tells us a couple things. One, it tells us that we don't always know what we need to treat our patients with. And number two, it tells us that Pete's a really bad guesser at picking antibiotics. Yeah, and I love giving him a bad time about this study, and he knows it, and he laughs. But an interesting thing is you take the culture, it might help, and it might even save an unnecessary surgery if you pick the right one. And patients love this, probably more than anything else. If you tell them, I'm not going to guess with your health. I want to take the time to do it. And why don't we do it? We don't do it when we're rushed. It takes extra time. You have to follow up on the culture. You have to document the antibiotic. You have to then call the patient or ask your nurse to call it. It takes about 10 minutes of extra time every time I take a culture. So it's painful. Craig Miller. Craig, raise your hand right here. Craig's one of our otolaryngology residents at the University of Washington, and he led this study. We just finished this. We looked at 230 patients who had sinus surgery. 230 where I took more than one culture during sinus surgery. Why would I take more than one? What a waste of money, right? That's kind of what I thought after a few years of doing it. And what this shows is the left frontal sinus is this more white, milky pus, and then the right sphenoid sinus is this thicker, gray, greenish, peanut butter type stuff. So if phenotypically there's different looking pus, that's when I take multiple cultures. And I thought, well, is this worthwhile or not? Well, here's what we found. 46% of the time, almost half the time, there were different pathogens in those cultures. So in the white milky ones, Staph aureus, and the green ones, Pseudomonas. And of those 46%, we changed antibiotics 25% of the time to cover both pathogens. Now that's interesting. Whether or not that affects patient outcome is a completely different story. The point of this conversation is take the cultures, follow up on them, and your patients will appreciate it just because you're not guessing with their health.
So I'm curious, actually, can we poll the audience on this one?
We can.
I'm curious, in your practice, those of you who do cultures, do you give the patient an antibiotic to start before you get the culture result back? Go ahead and raise your hand if you do that. And then you just change it. How many don't do that? Just out of curiosity. Okay, so everyone does it.
What about if it depends on how symptomatic they are? Right? So about half the time I do, if they're miserable, like if they come in and they're just miserable and I'm like, let's try something. I don't think I change 40, whatever it was, 77% of the time.
Pete changed 77%.
Yeah.
That's because he's using amoxicillin every time.
But I think if they're like, if they come in and they're like, well, I've had symptoms for a while and I'm holding steady and I can wait 3 days, then I don't give them something immediately.
I think it's reasonable to give them the option. And knowing the downside of giving them an empiric antibiotic right away is that you may be calling them in 4 or 5 days, and they might have to throw that antibiotic away if it's resistant. Yes, Al?
So the other reason I do cultures are the things I learned from cultures, and this is going out on a limb a little bit. If I find a pathogen that I can't pronounce, or on multiple different cultures, I think a lot more about immune complex problems or immune deficiencies. If I get nothing out of a culture that looks like pus, you think anaerobes, and you'll see my talk tomorrow, I think about bad teeth. And so there's other things you get from culture results other than just, this is the antibiotic we're going to use to treat this problem with.
True. All right, moving on. A short chat about drug-eluting stents. There's one company makes them. They're out here in the fishbowl. Not really allowed to say company names, but we know who it is. So drug-eluting stents, do you guys use them? And just give a general opinion about your use and what you think about it.
So I use them sparingly. I was excited when I first saw them coming onto the market. I thought they were going to be have some pretty significant advantages for some of my patients, and understanding the cost related to them and kind of evaluating that on a patient-by-patient basis. I find myself using them maybe 1 in 10 cases, something like that right now.
All right.
It's the patient with polyps that I'm trying to avoid a lot of oral steroids on. Maybe the diabetic patient with polyps, for example, that I've done surgery on. I'll definitely consider doing something like this to them.
And out of curiosity, anybody had a patient with avascular necrosis of the hip? Yeah. So, yeah, Dr. Tempero, my friend from Omaha, who trained here, we were just chatting about this, and you get one of these patients, and that's going to change your behavior quickly. So, Ray, what about Australia? Have they adopted it yet?
Well, yes, I use drug-eluting stents on every single post-operative patient, but they're not the commercially available drug-eluting stents. It's a spacer, gloved finger, glove finger with a spacer infiltrated with dexamethasone. And I'm allowed to say that because it's not any company at all. And yes, I use that in every single post-operative patient for a variety of reasons, but the biggest reason is when you take it out at a week's time, you've got a nice wide open cavity. It's really, really moist, and it actually promotes healing quite significantly. We've done studies looking electron microscopy sampling, and they do better with a topical steroid-eluting stent post-operatively.
Interesting. Look for Ray's infomercial on YouTube soon. That's nice. Sarah, down in Georgia, you have a lot of allergic fungal sinus disease down there. What are your thoughts?
So specifically in the allergic fungal patient, I rarely use them because their ostia are so blown out and wide that I don't usually use them there. I like Brent, I use drug-eluting stents sparingly in the standard sort of frontal ostium, frontal sinusotomy. I use them in my Lothrop cavities to hold grafts in place. And I'm still trying to figure out why some of the patients crust like crazy with these things in, and others look beautiful the whole time they heal. So if anyone knows the secret answer to that, I'm happy to hear it.
Well, hemostasis
Incidentally,
certainly
the Lothrop
plays a role,
cavity,
for sure.
the Lothrop cavity, as Sarah mentioned, that's
Yeah.
fantastic indication for this.
Yeah. Yeah. Alan, private practice has it.
So
penetrated?
yes on polyps when I can, and the when I can is we can when we do it at the hospital, and we can't in our ASC because nobody pays for it. And I'm still trying to figure out on non-polyps. I think sometimes on frontal revisions, I've done it and felt it helped, but I'm not sure. Sometimes you get a lot of crusting and you wonder if that's worse.
So I would actually echo the crusting issue. That's a real issue. I mean, I've seen some unbelievable messes in there with these things. And I think it's decent technology and everything, but it's not a panacea. And it definitely, some people clearly react against it. And I have a lady who I just saw actually right before I came out who had them after, she's a polyp patient, had them. Oh, are you okay? Yeah.
See, I think I should have a button that controls the seat height. If I don't like their answer, the seat goes down.
I feel I feel superior to you right now.
You always are.
Yeah, I mean, they can get really quite an inflammatory response. And I have a lady that I just saw just the other day who her cavity is totally erythematous. I mean, she's clearly having a reaction to the material there, and she is not doing well with it, despite the fact it's eluting the mometasone. So it is not a panacea. Be careful with them.
It's definitely something to keep in mind, though. And one thing I do like about, I use a ton of budesonide irrigations, and we'll chat about that later today or tomorrow. There's a couple things I like about it. It's a great spacer, but it is 100% compliance. So if I put it in, the patient's going to get the mometasone. I know that for sure. And if I have doubts in an inflamed sinus patient that they're not going to do their budesonide irrigations, this is something I can do to get them. Brent alluded to the study. This is part of the meta-analysis, but this was the recent one on the frontal sinuses. They looked at 80 patients. They took the propels out of the frontal recess after 3 weeks, and then an independent panel reviewed it. And I'm going to skip this, but the big take-home was a 38% reduction in need for intervention as determined by an independent reviewer. So decreased need for debridement, lysis of synechii, and steroids. And I have noticed my Lothrop rate has gone down. And
You mean your need to do a Lothrop?
need to do a Lothrop has gone down, and I'm not. I'm sure some of that is technique, but this I think can help in some situations. Something to keep in mind.
So I'm not sure, and I am well aware of the study, but I'm just not sure I buy it. I gotta be honest with you. I just feel like my patients with these things up in the frontal, they still need a lot of debridement. They get soupy up there. I have patients that have pain when they're up there as well. So, and then ultimately when it finally heals up, after 6-8 weeks or something, then it seems like it settles down. It looks great, but it's just not. I mean, I still do a lot of debridement. I still see a lot of stuff. I even have a beautiful video, which I don't know if I have it with me here, but I have a video showing a scar band forming over the propel implant, over the where you can see the little fibroblasts following along the little tentacles of the implant. So again, I just caution people. I think it's great technology. I think it offers a lot for our patients, but it is not a panacea.
Greg, can I just say one thing about absorbable dressings overall? So the one thing that you cannot ever be guaranteed about your absorbable dressing is that it's going to absorb. And it's been my experience that some don't absorb less than others. Sure. And there's some patients, you can put in an absorbable dressing in some patients, you go back 2 weeks later and it's just a block of scar tissue. And others, there's very little to see. So I don't think, as Brent said, it's a panacea that, it's the answer to all our problems.
I think
that's
the answer,
any form of absorbable.
Very true. Yes. I think the key is if it's crusted, take it out, right? And that's what this progress study did. They all took them out at 3 weeks. If you take it out at 2 weeks, it comes out in one nice piece as opposed to pick up sticks for 3 weeks, 3 weeks out. The final thing I want to talk about in the last few minutes is recurrent acute sinusitis. And both Brent and I want to talk about this in our panels. I think it's good to hit it twice because we both have different thoughts on this. But this is a classic case, 57-year-old female, 5th sinus infection that year. She responds to antibiotics, gets better between courses, and endoscopy shows some purulence during an infection. This is her CT scan. Really mild disease, but there's something there. This is how we define recurrent acute by the ARS and Academy, 4 or more episodes of bacterial sinusitis with resolution of symptoms. And so what do we do with this patient? Al, this is your patient in Spokane. It's not your patient. I'm making that up.
Maybe my
This
patient.
person
I got
walks
lots
in
of. I have a lot of these patients.
Patient walks in your office. What are you going to recommend?
So the first question is, when in the course of the disease is this CT done?
During the symptoms.
So most symptomatic day.
Yeah.
Did you do endoscopy, and what did
Yes.
you find?
Pus, inflamed tissue, right in the
Did
middle of the
it
meatus.
culture? Did you do a culture?
No, I was out of time that day.
And what was the duration of symptoms?
Let's say 3 weeks. I mean, it's a class. Let's just assume it's a recurrent acute. Let's
really-
say it's
really-
not a headache patient.
Really
This
true.
is truly
yeah,
recurrent
really
acute. I
true.
would call that recurrent acute. Would you disagree?
Yeah, if that's really what it is. If you got bacterial,
Well, you got the
infection,
CT scan right here. You tell me.
The disease is pretty minimal, and I would expect to see considerably more sinus inflammation at the most acute phase. But if you're telling me this really is truly recurrent acute bacterial sinusitis, not a headache disorder, I'll say fine, and we'll tell you what I would do. So in these people, many of them, and this I have a big allergy practice too. Surprisingly, they respond well to allergy immunotherapy. People that get, even if this is January when the allergies aren't out. So we typically do an allergy workup on these people and offer them that as one option. This is also isolated disease. It might be a good candidate if they're interested in a balloon procedure or something like that, when there's some economic issues with that, since it seems to be one sinus. And prevention. There's good data that you can prevent recurrent acute sinusitis by doubling the dose of Flonase, essentially, in the early acute period. That if you use, mometasone or fluticasone, 2 sprays BID right when they first get sick, that you can prevent progression to a prolonged disease. I don't know if Rain knows about this. The international thing, I went to an international thing in Germany, and they use even this herbal preparation called Sinupred that seems to work well for my patients too, to prevent recurrent acute bacterial sinusitis. Whether that's placebo or not, I don't know, but the German guys actually prescribe it like a medication. Okay. So there's my take on recurrent acute sinusitis.
I just want to know, would anybody offer surgery? Raise your hand if you would offer this patient surgery.
Eventually.
No, what you don't want to do, and I've said this time and time again, is convert your patient's headache into your headache. And I think that the second R in that RARS is really, really important. It's recurrent acute rhinitis, and that's the primary problem here. The sinusitis is actually a very mild secondary phenomenon. So when you're putting your scope in there and you're seeing some purulence and some mucosal edema, that's all inflammation within the nose. If you made a hole in the sinuses, you're going to see very little inflammation. It's evident there on the CT scan. So this is really a recurrent acute rhinitis with some mild secondary sinusitis. And I think that surgery in your sinuses, you're creating more problems than you're going to achieve.
So I'm sensing some hesitation here to offer surgery, and I'm glad to hear some of that. There's 2 studies that I want to point out. Peter's study looked at recurrent acute sinusitis. About half the patients got medicine, half the patients got surgery. In the surgical cohort, that's the red line, by 12 months on the SNOT-22, they did significantly better than the medically treated patients. So this came out a few years ago, and we're like, ooh, maybe we should be doing surgery. And then Tim and Jeremiah, they did another study looking at the 90 days before versus after sinus surgery. Significant improvement in the SNOT-22 scores, decrease in the number of antibiotics, decrease in loss productivity. So we have a couple studies recently that say, hey, there's some benefits here. And so I appreciate the caution that you're saying. There's a discrepancy, though. What do? We think we can make people better with surgery for recurrent acute. And now I'm hearing maybe
Accepting, I think your diagnostic criteria are different from the patient that you've shown us to the patients that Tim used in their study and Jeremiah used in their study, because they had radiologic and endoscopic evidence of ongoing sinus, of recurrent true sinus disease, whereas your patient you demonstrated here, to my mind, didn't.
All right. That's a good point. In our final 45 seconds, I just wanted to point out how Tim showed Haller cell, which is here, concha bullosa, and deviated septum can be risk factors for recurrent acute, certainly allergies and cigarette smoke. But this is one more shot of that patient I showed you. Healthy sinuses, right? I picked a slice where it was barely minimal, and the patient had symptoms on this day, but they weren't severe. I lied. Sorry, Al. And so I say, you got to come back when you're at the point where you have to have antibiotics, where you feel you're that bad off. They call my nurse, and they came back, and now they actually have real disease, more real disease, but it's definitely better or more significant than before. So, it's an option, but the point is be cautious when you're talking about surgery for recurrent acute. Yes, final comment.
I would argue that for me personally, I am evolving on this issue a little bit. I was very, very resistant in the past. I'm much more willing to consider it now. Some very limited type procedure in some of these patients, and mainly because of this type of data that's showing up. But be very cautious. I'm curious, actually, again, I'd be curious as to what the crowd thinks as well. How many of you would offer surgery?
Yeah, Jim, go ahead.
None of you mentioned irrigation, so consistent.
No, I think all that stuff is important. We didn't. There's a lot of medical type things we can do to help control these. I honestly, I tell my patients, wash your hands. I mean, there's a lot of things. I mean, most of the, oftentimes it's the mother of 2 toddlers at home and things like this as well, which makes it all that much more challenging.
To answer your question, I would operate if consistently doing irrigation.
Yeah. Doing all the medical management issues. Right. I agree with that.
So if you can't hear, Jim's a really good friend from Kenai, Alaska. Thanks for coming down again. He said he would operate if the patient was doing standard of care, irrigations and the nasal steroids on a consistent basis. Good. Okay. Great. Well, thank you, panelists. I appreciate your candor and your opinions. It's always nice. Ray, sorry we gave you the trick chair and it dropped you down a notch. We're going to move on to the next series of talks. And anybody heard of a Pichacucha? It's not a Pokemon character. So Pichacucha, my friend Chris Moe in the back, Dr. Moe, brought this up. Chris, was it 2 years ago at the American Skull-Base Society meeting? They did a trial of this, and he loved it. And he came back to Seattle and says, we got to start doing these. Pichacucha is designed invented, I should say, by 2 architects in Japan. And they wanted to really address this MTV soundbite generation. And the idea was there's rules. 20 slides, 20 seconds per slide on auto advance. And the goal was to keep people's attention. That there many, many studies show that most people's attention span is 10 to 15 minutes. Mine's probably 3. But doing it this fast kind of keeps it moving along. So I challenged my panelists to do a Pichacucha talk. We did it up at our Whistler ski meeting in January. And it's a lot of fun. It's almost on the edge of entertaining. It actually takes practice to be able to hit your time marks. But we're going to see. And Dr. Ayers, Drew Ayers is our allergist, our go-to allergist, one of our go-to allergists at University Hospital here in Seattle. And I've had many friends, colleagues, local ENTs call me and say, Greg, what are you doing different that I can do? And I said, well, I have Drew, and he's my secret weapon because he takes care of all of this incredibly complex medical issues that plague our chronic sinus disease and special polyp patients and asthma patients. So I've asked him to give our first Pichacucha talk, and I think your first Pichacucha talk that you've ever done. And we'll be gentle on him. I'll try not to razz you too much, but you will have a clock that starts so you kind of get an idea when your 20 seconds are going to go. But you can always use you guys, everybody else doing these types of talks, you can use the clicker to go forward or go back if you want. So we're not going to hold you to it immensely. All right?